Ήδη λίγο καθυστερημένη σε αυτό το πολύ ενδιαφέρον session με ειδικά cases από την ομάδα του καθηγητή Efthimiadi και όχι μόνο. Κύριος Αναστασάκης μαζί μας. Εγώ είμαι ο Πέτρος ο Nihoyannopoulos και ο Άρης ο Αναστασάκης. The session will be conducted in English, and I am delighted to call upon Dr. Despina Parcharidou to start up the session with Filamin C cardiomyopathy. Despina.
Good morning from me as well. I will start my presentation with the structure of Filamin C protein. This protein has an N-terminal end, which is an actin-binding domain, and a C-terminal end, which interacts with many binding partners. The protein also has ROD1 and ROD2 subdomains and two hinge regions. The hinge region help the protein to bend and form a dimer. Filamin C has vital role in bridging the cytoskeleton and extracellular matrix in cardiomyocytes. The most amount of filamin C is localized in Z disc, where it can interact with actin, and also in smaller amounts it localizes in the costamers and the intercalated discs. So, different filamin C variants can cause different cardiomyopathy phenotypes. Filamin C arrhythmogenic cardiomyopathy is a disease caused by truncating variants, which by haploinsufficiency can cause weakening of myocyte adhesion. Filamin C hypertrophic cardiomyopathy is a disease caused by missense variants, which via protein misfolding can cause a formation of aggregates in the sarcomere. In this study of 85 filamin C truncating variant carriers, 45% of them were probants. As you can see in the gene map, truncating variant distributes throughout the protein with a cluster in actin-binding domain and a bigger cluster in the ROD2 domain. According to the results of the study, the location of truncating variant does not modify the severity of the phenotype. And I will start with the first family. The proband is a female, 60-year-old. The reason for screening were many episodes of tachycardia and dizziness. She had an unexplained syncope 13 years ago. She had felt tachycardia for 15 minutes approximately, and then she collapsed. The Holter showed 3,500 PVCs. She has a very abnormal ECG, a very low voltage ECG with Q waves, V1, V3 leads, and also PVCs from the left ventricle. And as you can see from the echo, there is hypokinesia in the posterolateral wall and the basal inferior wall. And from the MRI that it was performed by Dr. Karamitsos, you can see the gadolinium enhancement, which is almost circumferential. It is known since 2016 that filamin C can cause a dilated cardiomyopathy phenotype with high risk of arrhythmias and high incidence of family sudden cardiac death. And in the MRI, it shows a characteristic appearance of ring-like subepicardial gadolinium enhancement. From the ECG, it can have low voltages ECG and negative T waves. So, the patient had an ICD implantation due to the syncope and the presyncopal episodes of arrhythmic origin, and the genetic test result revealed a mutation in filamin C, a likely pathogenic mutation, which is an intronic variant of an exon 44 in an exon 44 splice site. So, introns are non-coding variants. Splice site mutation occurs at the boundary of an exon and an intron, then that is the splice site. So the introns lies between two exons, and the boundary between the intron and the previous exon is called the donor site, and the boundary between the intron and the next exon is called the acceptor site. So the mutation of our patient was at the acceptor site. It is known that gene splice mutation in filamin C cause dilated cardiomyopathy, and you can see in the table the phenotype characteristics of DCM-affected individuals with Filamin C variant carriers from 3 families, and the carriers showed an arrhythmogenic trait with high incidence of sudden cardiac death. And now we continued with the family screening. The son is 34-year-old. He has palpitations. He is a functional class 1, and his Holter was unremarkable. But as you can see, he has a pathological ECG with borderline low voltage, Q waves in the inferior wall, and abnormal R wave progression in the precordial leads. And also from the echo, he has hypokinesia in the posterolateral wall and the basal to mid inferior wall. The daughter is 37-year-old. She has palpitations, no syncope, very abnormal ECG that resembles her mother's ECG, very low voltage ECG. And we asked for her to put on Holter monitoring, and this is the result. And you can see the very fast episodes of non-sustained ventricular tachycardia. She had an ICD plantation, and the genetic test result revealed the same mutation that runs in the family. The echo shows, okay, the echo is, okay, συγγνώμη γιατί. Okay, so as you can see now the handmade family tree. And I always prefer to show you the handmade family tree as we do it in cardiomyopathy clinic in everyday practice. And you can see that this mutation in the family has a high arrhythmogenic trait. You can see how many sudden cardiac deaths in young age, approximately in 50 years old. So I will continue with the second family. The proband is a boy, 16-year-old boy. The reason for diagnosis was atrial fibrillation, no syncope, no palpitations, and the Holter monitoring was unremarkable. From the ECG, you can see a little bit wider the QRS for a 16 and the negative T waves in lead 3. So now you can see it was. Okay, now it's the right slide. Now you can see the echo of the boy, and it is normal echo, normal ejection fraction, normal dilation, dimensions, everything looks normal. But as you can see from the MRI, there is a gadolinium enhancement in subepicardial lesion of inferior and posterior wall. 3 months later, before the genetic test results, his brother died, age 13, suddenly. He suffered from acute amygdalitis, and the autopsy revealed acute myocarditis. And here is the proband's brother post-mortem histological analysis. And you can see with the pink color the cardiac cells, and with the purple color, like peppercorns, the lymphocytes. So here is an infiltration of inflammatory lymphocytes. It's an inflammatory situation. It is that is because of the myocarditis. So in the next slide to the right, with the arrow, you can see some myocytes, that's cardiac cells necrosis, the damage of the cells. And in the picture below, there is a possible indication with the arrow of aggregates. So the genetic test result of the proband revealed a Filamin C pathogenic mutation. It is a nonsense mutation. And we did also a post-mortem test to the brothers of the proband that he was deceased from the myocarditis, and he was a carrier of the same mutation. So it is known since 1996 from Cristina Sbasso, Domenico Corrado, and Gaetano Tene publications about myocarditis and ARVC. And we know that genetic defects in cardiomyocyte structural proteins, like Filamin C in our case, could confer increased vulnerability to myocardial inflammation triggered by a causative agent such as viral infection. For our case, for the brother of the proband, it was the amygdalitis. So during the period, we have a genetic predisposed boy that had a viral infection, an amygdalitis, and that causes the myocarditis. And during the periods of myocardial inflammation, there was an elevated arrhythmic risk, which led him to sudden death, unfortunately. And now, what about the mother of the boy? She's 46-year-old, she's asymptomatic, normal echo, MRI, no LAGAD, PVSS in Holter monitoring 1,500. She has a near normal ECG, only a negative T wave in lead 3, and the genetic test result revealed the same mutation that runs in the family. So, except from the typical characteristic phenotype of the Filamin C that I've shown you in the first family, arrhythmogenic cardiomyopathy associated with Filamin C variants can present with a distinctive phenotype characterized by Holter arrhythmia and LAGAD on CMR with unremarkable ECG and echo findings, like in the mother. And this is the family tree. We don't have a lot more information, only in the maternal side, the grandmother died in her 60s. She had CABAs and pacemaker, and from the maternal grandfather, we have some strokes. And the last, third family, it's about a male, 63-year-old. He suffers from hypertrophic cardiomyopathy. He diagnosed 10 years ago due to angina. He's functional class 3, no syncope, no palpitations, ECG typical for hypertrophic cardiomyopathy. He has, from the echocardiogram, a phenotype of hypertrophic obstructive cardiomyopathy, and the genetic test result revealed a Filamin C missense variant, which was a VUS. It means a variant of unknown significance, but with high pathogenicity. You can see the in silico predictors that they are pathogenic. And in this study, sequencing of 92 HCM cases identified 7 additional missense variants segregated with the disease in 8 families. And you can see the heart samples from 2 patients that carry the mutation, and they had transplantation. You can see in the control first that the myofibers, the myofilaments of actin and myosin, are very well arranged, and they give a cross-striated appearance. But in the hearts of the patients with a mutation, you can see the disarray inside the cell and the disorganization of the muscle fibers, and also you can see with the arrows some aggregates. And with the help of immune histochemistry, there is an indication of Filamin C inside in the aggregates. So, in another study, in hypertrophic cardiomyopathy patients that screened for Filamin C gene, you can see in the table the main clinical features of the HCM index carriers of the Filamin C gene. And you can see that from 18, we find in 18 patients, they find in 18 patients missense variants, and 8 of them were VUS. It means variants of unknown significance. So the candidate variants were associated with mild forms of hypertrophic cardiomyopathy and reduced penetrance, making difficult their final classification as pathogenic. The available evidence for pathogenicity is still limited for most types of missense Filamin C variants, and this is in contrast with the truncating variants that are most likely pathogenic and cause arrhythmogenic cardiomyopathy. So, in the AHEPA cardiomyopathy clinic, we follow 5 families with Filamin C mutations, and here you can see the characteristic of the probants. 4 of them, they have a loss of function mutation, and the one of them is the missense mutation, which was the VUS. I already presented the 3 of them. So the youngest was 16-year-old, and the oldest 59 years old. They all diagnosed due to symptoms. The one is diseased with a loss of function mutation, and they had ventricular arrhythmias and pathological ECG, except that one. The one with the loss of function mutations, the phenotype was arrhythmogenic cardiomyopathy, and the hypertrophic cardiomyopathy was the phenotype for the missense mutation. All of them, they had late GAD, and all the probants with the loss of function mutation had the ICD implantation. And that's all from me. Thank you very much for your attention.
Thank you, Despina. You've done fantastically well. So your English is marvelous. So from now on, all presentations in English. We have well, limited time, but as an imaging person, I would be very disappointed because imaging is in Filamin C mutations is pretty useless. Both MRI and echo can show sometimes, in extreme cases, some pathologies, hypokinesia, some non-specific fibrosis on MRI, but really non-specific. And from the pathology point of view, Mary, if you come across a heart without having had an ECG or a Holter monitors, can you make a differential diagnosis of this patient who died suddenly?
A very good question.
Can we have a microphone? Microphone in front, please. Μικρόφωνο αν μπορούμε.
Very challenging question, thank you. The majority of the cases I look at have had no previous ECG, so I'm often not aware. And even when I get a clinical history, I don't get the full history. So I make a diagnosis, which I'll talk about later, on purely morphology, whether it's arrhythmogenic spectrum, dilated spectrum, or the hypertrophic cardiomyopathy. But I cannot, you are absolutely right, I cannot predict a particular genetic mutation. Maybe in the future with correlation we will, but not at the moment. Oh, it's closed. Oh, it's closed. Thank you. I hope people heard. But I can make a phenotype diagnosis, but not a genetic. I think with the future and more subtle, and you're right, imaging is not the answer to every cardiomyopathy either. It's a multidisciplinary combined approach, I think. But we're increasing our knowledge enormously, but it also emphasizes the complexity of Filamin C. Thank you for such an excellent talk.
Mary, also Despina showed the slide that you just popped out at this point with the myocarditis patient, the child that died suddenly, who had both the myocarditis
and Filamin C.
Can you show again the slide?
Oh, I would. Yes, because we see cases like that where there is.
Next, they have to. Θα με βοηθήσετε γιατί θα βάλω την επόμενη ομιλία.
Yeah, just go back, because that was an important slide, I think, that showed two pathologies.
And I see that. We have a subset, particularly of arrhythmogenic cardiomyopathy cases, where we see epicardial inflammation in the sudden death group. It's a small group within arrhythmogenic, but there is definitely what we call a hot phase of pathologically, where we prove there's inflammation in the myocardium.
You can make this one comment maybe.
Oh, yes.
The slides. It's from the myocarditis, the patient that died suddenly.
And you can see inflammatory cells there. There's no doubt there is an inflammation combined with the genetic mutation. I think it's the future will be teasing out these cases that are, as you say, the combined, the double whammy of the underlying genetic with the superimposed inflammation. Whether it's viral linked or not, I do not know. We have not localized viruses in these cases, but it's a challenge in this subset of particularly arrhythmogenic. We don't see it in dilated or in hypertrophic inflammation that much. But in a subset of arrhythmogenic, definitely, and these are the ones that die suddenly.
Bill?
Just to second your enthusiasm for imaging in the context of depends whether you're seeing a patient who's 18 and has died suddenly or who's 54 and has heart failure. And with Filamin C, the first major paper on this in terms of arrhythmogenic cardiomyopathy was from the Lorenzo Montserrat group, and it's in JACC, and there's 23 families. They looked and they said, okay, Filamin C causes skeletal muscle disease, causes restrictive cardiomyopathy, causes hypertrophic. I don't believe that, but it's published. And so let's look and see. So they looked on their database, and they found under DCM a whole bunch of Filamin C patients. And when they looked at the 23 families, they were mainly Spanish. Basically, you had sudden death in young men particularly, and heart failure death in older people. And when you drill down on the young people who died, they're very frightening because their electrocardiograms were not dramatically abnormal, but they had arrhythmia of left ventricular arrhythmia, but they had late GAD. And that's a beautiful paper from Martin Ortiz Genga in JACC. And then we looked at that same time, we looked at our patients who didn't have a normal desmosomal variant. And we had, I think it was 9 families or 8 families, but small number, but sudden death in young men as the initial manifestation. And the frightening thing is the echoes were unremarkable, and the electrocardiograms were not dramatic. But they had 100, 200 ectopics, non-sustained VT, and they had late GAD in the typical fashion. So tricky because it's a disease Filamin C depends on age and when you see the patient.
Okay, well, it's very exciting conversation. We have another comment from Professor Franco Cecchi, who is online. Can we have another comment, Franco? Are you still there?
Here.
We can hear you, we don't see
Hello,
you.
guys. Good morning. Good morning to you all. I heard the beautiful lecture by Despina. And actually, I understand that, we're really, it's a work in progress. We're learning every day, watching these families, analyzing these sudden death cases, and working together with pathologists and geneticists. So I don't know if, it's the time to make a question, but I just wanted to compliment you for the moment. So let's go on and let's hear the next speakers, and then we shall have a discussion at the bottom.
Okay, Professor Gatsoulis, and we move forward.
A very short question. From Padova, cases of Wolf Parkinson White who died suddenly and had pathology, so they also had acute myocarditis as a cause of the atrial fibrillation. And if the atrial fibrillation is conducted through a very fast conducting tract, might be a reason for dying. Also, I think there are a lot of unrecognized acute myocarditis cases, and I'm wondering whether what we name flare-ups among DCM and arrhythmogenic right ventricular cardiomyopathy from your excellent groups might be a real situation in other heart disease patients as well, like coronary artery disease or DCM of no genetic origin. Can you make a comment?
Maybe Professor McKenna, that was a difficult one. I really am not experienced with.
So there's multiple topics there.
Yes.
I mean, each one is a lecture, but let's just leave the last one, myocarditis. Michael Davis, Mary's mentor, said myocarditis is the diagnosis of the destitute. It's what you say when you don't know. Yes, it's there. What is the cause? Why is that myocarditis there? And that's essentially, so if you see an impaired heart example that we've seen, what is the underlying cause? The myocarditis is the inflammatory phase of what disease? And most of them are genetic. So if you look at just take ARVC, the Spanish group, Juan Jimeno from Murcia follows a group of patients for 4 years, and I forget, it was about 6%, I think, had during a 4-year period a clear episode of myocarditis with a hot phase of arrhythmia. And the arrhythmologist calls it a hot phase, the immunologist calls it myocarditis, the pathologist would call it myocarditis, but it's part of the process, And is it immune, autoimmune, inflammatory? Hard to define, but the inflammation is a key part. And the original studies from Gaetano and Christina Basso, 1996, 30 sudden deaths. I think it was 60% had evidence of myocarditis in the sudden death.
For mitral valve prolapse were dying suddenly?
Yes.
Yes.
Okay, I think we have this conversation will never end. We will move on. Thank you very much to Despina. Fantastic.